Good evening, everyone. I'm Dr. Ashita Punjabi Hakku on behalf of IFS MP chapter and SIG group. I welcome you all to one another session on our series on genital tuberculosis. I'm very grateful to our president, Dr. Colonel Pankaj Talwar sir, Dr. Shweta Mittal, Dr. Priya Bhave Chittawar, Dr. Sonu Balhara, and Dr. Nitin Lat sir, who have given us a platform where we can discuss a critical issue, which is genital tuberculosis. Today with us is Dr. Rana Mondal. Can we have the slide, Dr. Rana? Dr. Rana Mondal, he is MS Obs Gynae, DNB, and he is FNB Reproductive Medicine from Bansal Hospital, Bhopal. He has an excellent academic career. He is MRCOG. He is also European Fellow of Reproductive Medicine. He has done quite an extensive work on genital tuberculosis, and he has many publications to his name. With much ado, I am handing over the session to Dr. Rana. Dr. Rana, you can share your slides.
Thank you, Dr. Ashita. And I would like to thank the IFS team, Indian Fertility Society, especially the MP chapter, Madhya Pradesh chapter, for conducting such a sessions and for giving this opportunity to share my work in this platform. Thank you, Dr. Ashita. Can I share my slide?
Yeah.
If my slide is visible to everyone?
Yes, sir.
Thank you. So shall we begin?
Yeah.
Okay, fine. So today's topic is the laparoscopic and hysteroscopic diagnosis of female genital TB. Before we begin, I like to highlight the importance of the female genital TB. That for the couple, those who are aspiring to conceive, female genital tuberculosis emerges as a silent disruptor, and it casts a shadow over the canvas of infertility, and it has some intricate complexities. And one of those complexities are how they are affects the reproductive organs and what we can see through the lens of the hysteroscope and diagnose inside the pelvic organs. So I would like to highlight the common findings that we get in the hysteroscopy and laparoscopy in those women who are affected by the female genital tuberculosis, and how the findings are important to it. I will discuss through this thing. In today's session, I will go through these topics. First, I would like to review some basic things about the female genital tuberculosis. Then I would like to highlight what are the current diagnostic tests available and what is their with backdrops and also how important those are, and what are the problems with the female genital diagnosis of in this, especially the subfertile women. And then we'll come to the hysteroscopic and laparoscopic findings. I will like to focus on the key findings of the female genital tuberculosis, and then I will come to the what are the important findings and how these findings are predictive to the tuberculosis. That is the clinical practice point you need to know. So first, come to the basics. All of us living in a country where TB is quite prevalent. But do we know the actual evidence of the female genital tuberculosis? And most importantly, what is the actual incidence or prevalence of female genital tuberculosis, especially in the subgroup of subfertile population? Can anyone tell me? The true answer is that female genital tuberculosis incidence is elusive due to the underreporting. And most importantly, the asymptomatic cases, the vague symptoms, and the diagnostic challenges compounded by the profound comorbidities and contribute to this enigma. The reported rates do vary by region to region, mirroring the pulmonary tuberculosis and abdominal TB. And this is also influenced by the socio-economic and public health factors. Genital tuberculosis do represent around 15 to 20% of the extrapulmonary tuberculosis. It was from a paper by Dr. J.B. Sharma published in 2014. Whereas a Swedish publication showed that the female genital tuberculosis incidence is around 20 in 10,000 population. And also worldwide, these incidents do vary. The World Health Organization guideline says that around 7.8 cases per 1 million population affected by tuberculosis. So why this is so important? In our country, tuberculosis diagnosis, the government invests lots of things and it costs so much. But the important thing is that there is still no diagnostic criteria or diagnostic setup to identify the population we are discussing, that is the infertile or subfertile population. Most of the focus and resources are contribute to the diagnosis of pulmonary tuberculosis and also the extrapulmonary tuberculosis. This is the sum of the important studies you can see over here. They have used different methods and various methods, but the true conclusion we don't have the actual findings of it. Now coming to the next point, what are the risk factors of this tuberculosis are? The risk factor of the female genital tuberculosis encompasses by the immunosuppressive condition such as the HIV, also the diabetes, any chronic comorbid condition like chronic liver disease, renal alignments, malnutrition, etc. Additionally, for Indian scenario, poor housing, homelessness, and pneumoconiosis, vitamin deficiencies, immunosuppressive medications do contribute much more. Infectious pulmonary tuberculosis is notably more prevalent in the males. When we are discussing the couple with the female couple, we should not forget about to take history of the male partner for tuberculosis also. Individuals undergoing renal dialysis for chronic renal failure also is in high risk. These factors significantly elevate the risk of contracting and spreading the disease of tuberculosis. So whenever in your practice you see the couples having such a high risk, you should consider the diagnosis of female genital TB or keep an eye or suspicion to rule out female genital TB in such patients. It's very important. Unless you have a high index suspicion for a female genital tuberculosis, it won't come out because most of the subfertile couple will come to you. They are young, much more, and healthy also. Now, coming to the what are the pathogenesis and the mode of spread, they usually have a four types of spread method. Most are the hematogenic, others are the lymphatic, and some are direct spread, and some are the contaminated spread. Hematogenous spread are most of the common spread for the female genital tuberculosis. I won't go much details about the modes of spread as most of you will be knowing these things. Coming to the how does it affects to the reproductive organs, I would like to highlight the fact that remember the most often the female genital tuberculosis begins with the fallopian tube, and almost certainly if you find a case diagnosed with a female genital tuberculosis, almost 100% of that will be affected. Patients will have fallopian tube involved. The next most commonly involved organ in female reproductive system is the uterus, mainly the endometrium. And the cervix and the vagina involvement is quite less. Ovaries can be involved in around 30% of cases. Remember, most often the infections start from the submucosal layer of ampulla, mostly via the hematogenous spread. They usually spreads medially. Most often it is the most vascular than the outerwards area. So the most often the muscular layers are involved and can have various manifestations like fibrosis, segmental thickening, and late pipe appearance, tobacco pouch appearance, etc. Sometimes it will block the tubes. We can have hydrosalpinx or pyosalpinx, and sometimes we can have classical findings such as salpingitis smygnolosa. Sometimes it do involve spreads towards the outerwards and can cause perisalpingitis, and then the exudations begin, and then it crosses the fallopian tube border and involved to the abdominal organs where you can have adhesions, and can sometimes the peri-ovarian adhesions form, and later it can turn into the tubo-ovarian mass also. Whereas when uterus layer, that is the endometrium, gets involved, tuberculosis begins at the basal layer of endometrium, shades at each menstruation, and again reinfect, and at the end, this process leads to the endometrial ulceration. And this ulceration, when chronically infected, it turns into the additions of various grade forming Asherman syndromes. Most often, endometriums are involved. Very rarely, myometrium can be involved also, and it can, if the myometrium get involved, it can lead to the pyometra formation also. Now I will come to the different findings, the different tests that we use to diagnose the tuberculosis in the subgroup of female infertile population. I won't be discussing anything related to the diagnosis of genital TB or extrapulmonary tuberculosis. I am only concerned in here regarding the infertile population. Now, there are various findings on hysterosalpingogram in literature, if you see, and there are many names, everything, but I would like to highlight the some common basic things here. I will come to the different findings in the next slide, but most often the tubal occlusion is the most common findings of the female genital tuberculosis. Why it's that? Genital tubal occlusion represents the prevailing radiographic discovery in the cases of genital tuberculosis when HSG examination was done. In 1960s, most of 60s to 1980s, HSG was one of the methods to diagnose the tuberculosis, female genital tuberculosis in the infertile population. The fallopian tubes have structural changes in such cases are characterized by multiple constriction which gives rise to distinctive bands, that is a beaded appearance of HSG images. I will show you to the images first. These are the images that I would like to highlight. But why these findings begin from the ampulla layer, that is the most important thing you need to understand. The fallopian tube structural changes can be characterized by multiple constriction, which gives rise to distinctive beaded appearance on the HSG images. That is what is commonly known as beaded tube appearance. Additionally, extensive scarring when happens from the beaded tube, the fallopian tube imparts a visual impression of a rigid slate pipe system, which is also a commonly known finding for the female genital tuberculosis. HCC can reveal several other noteworthy features of the genital tuberculosis like tubal dilation, the presence of hydrosalpinx, irregularities in the tubal wall, the presence of calcification. Tubal tuberculosis diagnosis is guided by the various HSG criteria, including calcification, tube obstruction, constrictions, jagged contour, distinct shape. Some findings like Maltese cross, Rossetti and leopard skin, cotton wool plaque can also be seen. Here you can see the golf club appearance or cobblestone tube and beaded tubes. And another important, whenever HSG you are showing, you need to see the uterine cavity also. Tuberculosis induces uterine changes, encompasses the specific features like collar stud abscess or T-shaped uterus. Sometimes it can form pseudo-unicornuate uterus, as well as specific alterations such as synechia formation, uterine contour distortion, cavity obliteration, and sometimes you can see vascular intervasation. Contrast invasion was notably observed. One of the study which can form the irregular angular stellate-shaped synechia if presence. Chronic infection can lead to the extensive destruction, causing something known as Natter syndrome. What is that Natter syndrome? It is depicted on HSG as a golf finger appearance, including that includes the cervical canal as a small part of the uterus. Here you can see the summaries of all these findings. Here I have classified it according to the involvement stage. If the fallopian tubes involved, you can see all these findings like multiple constriction, rigid tube appearance, SIN, which is a very characteristic findings for the FGTB. Other findings such as hydrosalpinx, rosary beaded appearance, cotton wool plug appearance, leopard skin appearance, all I have showed in the images in previous slide. Whereas endometrial involvement can have some specific features, some can have non-specific features. Non-specific features are more common. Almost 80% have non-specific features, most often the synechia formation, Asherman syndrome, uterine contour distortion, and intravasation. Specific findings include the pseudocornuate uterus, T-shaped uterus, or the dwarfed uterus, and the I already mentioned about the Natter syndrome. Cervical canal involvement can lead to the cervical filling defect, irregularities of the cervical lumen, or can form diverticula. Also, sometimes peritoneal involvement can give rise to the crisscross seal pattern, severe peritoneal adhesion leading to the visualization of irregular septation. Now coming to the other common methods used are the ultrasonography. In cases of female genital tuberculosis, fallopian tube exhibit the dilatation, thicken, and can be filled with either clear fluid, that is the hydrosalpinx, sometimes can be gaseous fluid can form, which gives rise to the pyosalpinx appearance on the ultrasound. So in the four parts we are actually saying in the fallopian tube on ultrasound, if you see these two findings, you can think of the female genital tuberculosis. Of course, it is a very non-specific finding. If then coming to the endometrium, what we can see on ultrasound, endometrium is affected significantly in the tuberculosis patients, and they do appear heterogeneous to hyperechoic areas, sometimes can give rise to the metaplastic calcification and also the fibrosis and adhesion. Changes of endometrial thickness, vascularity, uterine artery flow monitoring is very important, especially if you are planning for a embryo transfer. These things you need to keep check, and often it become very difficult to get optimum results when you are planning for an embryo transfer for such patients. Coming to the other radiological imaging, that is the CT scan or MRI. Abdominal and pelvic lesions are often accompanied by the ascites. Potential lymphadenopathy are observed through the diagnostic images. CT scan are highly effective in detecting the calcification, that is the pelvic lymph nodes, which are strongly support of diagnosis of FGTB. MRI can employed when assessing the abdominal pelvic mass. That can be useful also to ovarian mass. PET scan can be sometimes can be useful because the higher intake of the fluorodeoxyglucose within the TB affected area can be seen. Coming to the other findings that we are having, that is the endometrial biopsy. The The endometrial sample is crucial for diagnosis is ideally obtained during the premenstrual phase, either via aspiration or biopsy. The procedure is particularly important for the sexually active woman and should be performed between day of 21 to 24 for a regular cycle with ensured contraceptive measures to prevent unintended pregnancies. Techniques can be used as a Karman cannula or people or endometrial curettage, all can be used to diagnose it, and a portion of it should be sent for the histological examination and another should be sent for the other microbiological or molecular examination. Menstrual blood testing. Menstrual fluid collected from the vagina on the first day of menstruation is a practical approach for diagnosis of FGTB, primarily because the endometrium is frequently involved and easily accessible for blood sample in these days. While some recommend the bacteriological examination of the menstrual blood, including the AFB smear and culture, the sensitivity of these tests is very low. A study showed that the culturing of menstrual blood collected within the onset of 12 hours can detect only around 10% of tuberculosis. So it is a very not much useful for diagnosis. Coming to the histopathological findings, histopathological typical finding of TB is characterized by the granulomatous caseous lesion. However, these lesions are not exclusive for TB. They can be seen in syphilis, leprosy, fungal infection, and in other scenario also. HPV finding may include the isolated granulomas caseation also. Chronic salpingitis is a feature of non-caseating granuloma in the early stages of tuberculosis. Other when you are doing, you can use the MUM1 test also to know the state of chronic endometritis in the patients with suffering from the female genital tuberculosis. Coming to the other methods, that are the culture or radiometric test or backtake. Remember, the culture methods can be used as solid or liquid medium, most often the LJ medium, Lowenstein-Jensen medium, or Middlebrook solid culture are used. Automated backtake microbacterial growth incubator tube 960, that is most commonly known as MGIT 960, can also be used. Liquid culture takes at least 9 to 10 days for positive result and 6 weeks for a negative result. Therefore, culturing is not a quick process. A minimum of 4 to 8 weeks is required for a positive LJ medium culture. So you need to counsel the patient when you are sending for the culture method. The time it's a time-taking process. Other the methods are the smear methods. That is acid first bacillus staining method. That can be used, and also you can use the other method. Other methods. Montauk test is not specific for the our subfertile group of population. Coming to this, one of the important, that is the quantiferon gold, TB gold test method, most commonly used by many clinicians still now. It uses the interferon gamma that is sensitized by the T cell after stimulation by the tubercular antigen, and it was a FDA approved test. Tuberculosis disease, when in latent phase, we cannot distinguish them. What are the advantage of this test? It has a rapid diagnosis within a 24 hour. It gives a result in a single visit. You can get the result. It's a higher specificity for the mantus. Okay, and no booster response can be seen in this test. These are the few advantages. I'm not going to details about the how the test performs. What are the basics of the test, as most of you already know it. Coming to the another important test, that is the gene expert or MDV assay. Most often, it is a commercially available cartridge-based nucleic acid amplification test (CBNAT) designed for diagnosis of Mycobacterium tuberculosis. It is an innovative test provides the confirmation in just 2 hours and relies on the polymerase chain reaction to analyze the specimen. It can be found used any type of sample or bodily fluid. But the important thing is that simultaneously it detects the presence of the RPOB gene, which is associated with the rifampicin resistance. So it is a very useful thing. PCR is a fast molecular test and takes around 2 to 12 hours to complete the procedure, and it can identify as little as 10 bacilli per ml and even the dead bacilli. That is a drawback. Why that? Because it has a higher sensitivity and specificity. ATT should not be initiated on the basis of positive PCR result, and so you need to keep in mind that whenever you see the positive result on only on the gene expert test, you cannot initiate the ATT. Even the dead bacteria do give the positive result here. These are the a few other methods of test are can be used. These are commercially available. Some centers do using it nowadays, but I will like to go skip these states in details. I will come to the more important thing. Why the diagnosis of subfertile women, these tests are not good enough and what the drawbacks are there. This is the most important thing you need to know around all these tests are not be enough to diagnose of female genital tuberculosis. Why so? Epithelioid granulomas are the primary histological features in the tuberculosis, and it can be seen in other types of settings also. Caseous granulomas with large epithelial cells are specific to the TB, but can be observed in various conditions, as I have already mentioned, like in SLE, rheumatoid arthritis, fungal infection, sarcoidosis. Making irrelevant to the history is very crucial. Proliferative solid epithelioid granuloma, giant cell, lymphocytic infiltration all suggest the chronic inflammatory state and or the lesions indicative of the tuberculosis. It is neither the specific. Acid fast staining and the fluorescent methods are rapid for every detection but with variable sensitivity. Positive result for the tuberculosis in culture is a diagnostic, but it is a time-taking process also. And more importantly, the cutoff of the positive result for the acid fast staining for the endometrial curettage is a 10 organism per ml, which is often can be missed if the samples are not taken properly. Collecting the menstrual fluid from the vagina on the first day of menstruation allows the most optimum identification of the menstrual blood. The presence of Mycobacterium tuberculosis in the culture is a diagnostic of tuberculosis. But one of the Indian study has showed that 8.3% of the infertile women evaluated to had a positive for AFB smear and only 5.2% had a positive AFB culture. Premenstrual samples tested positive for the LG media at the rate of only 1.83% and the backdate around 8.8. This was a research by the Goel et al. Automatically coming to the MTB RIF assay, these tests do detect with a 30 to 50% sensitivity and 100% specificity for the diagnosis of female genital tuberculosis. So the point is, although there is a no gold standard method exist, the traditional methods like histopathological examination, AFP, smear, microscopy culture remains the crucial method of diagnosis of female genital tuberculosis, but they cannot always detect the female genital tuberculosis. So coming to our key concern of this chapter, that is the hysteroscopic and laparoscopic findings of the female genital tuberculosis. I will first focus on the key hysteroscopic findings on what we can see in the patients suffering from the female genital tuberculosis. Then I will come to the um, laparoscopic findings. One of the key findings are the micropolyp. What are the micropolyps are? Here you can see a small sprout of polyp. These are the micropolyps. Micropolyps are endometrial ingrowth with vascular axis that is less than 1 millimeter in size and floats on the uterine cavity on hysteroscopic fluid. Here you can see a small micropolyp, which is a very classical one also. Here you can see another micropolyp. This is the small finger-like ingrowth, and yeah, here you can see another micropolyp here. So if you see such kind of findings, they are suggestive of chronic endometritis. Micropolyps can be seen in other conditions in chronic endometritis or infective state, but it can be seen in the patient suffering from the tuberculosis also. In a study, it has shown that the women suffering from the positive tuberculosis, around 44%, we can see the patient having the micropolyp. Coming to the next finding, that is the caseous fluid or caseous plug that we can see on the hysteroscopy. Remember, the endometrial tissue necrosis is characterized by the formation of a cheese-like or crumbly friable material on fluid of hysteroscopy. This cheese material is seen as a oily floating material. You won't see this. You can see here how the oily it becoming. It's a slightly oily material is coming from the, and most often it comes from the area of the ostia or near the fundal area. Here you can see both ostia, it's in ostia where you are seeing the oily materials are pouring inside. Sometimes this cheesy material floats in the hysteroscopic fluid also. Sometimes you can see this small hysteroscopic caseous plaque are blocking the cavity area. That is a cheese-like material they formed and floats in the hysteroscopic fluid. And it, when the hysteroscopic fluid is going in jet, they try to push and go inside the tube also. So you can see that due to the jet fluid of hysteroscopic, it is around the ostia. Coming to the next findings are the focal hyperemia and diffuse hyperemia. Focal hyperemia is a focal hyperemia where is a focally there is a localized reddish area of endometrium with increased blood flow within that tissue. These are nothing but the early stage tuberculosis manifestation can be seen in the chronic endometritis also. Here you can see only punctate areas are infected. Whereas in the diffuse hyperemia, you, you will find an increased endometrial blood flow that is broad, affecting the broader area of the endometrium and gives the uterine cavity the impression of being carpeted in crimson. This happens as the blood arteries dilate, allowing more blood to flow to a bigger region or the whole uterus sometime. Coming to the next findings, that is the pale endometrium. Uh, Pale endometrium are often a common finding in the patient suffering from the female genital tuberculosis. Can be seen around 57% of women positive diagnosis of female genital tuberculosis. Endometrium appears as lighter or paler than the usual and atrophic in nature. It is a result of the chronic tubercular infection leading to thickening of the endometrium. Tubercles are very classical diagnosis of the endometrium. Here you can see the small tubercles on the around the cervix. Sometimes you can see inside the cervix and sometimes it can be seen on the outside the cervix. Here you can see the tubercles are around the outside the cervix. Another finding is the difficulty of distension of uterus when you are trying to distend the uterus with the hysteroscopic fluid medium. These are due to the shrinking the cavity. Typically, it refers to a condition where the size or the dimension of the uterine cavity are reduced or smaller than the normal. It implies that the uterus capacity has decreased because of the fibrosis of the muscle layer caused by the tuberculosis. Nothing but reflect the involvement of the muscle layer of the uterus. Here you can see how even in the forceful fluid checks how the both uterine wall are closed. Okay, even at the frontal area when we're seeing everything, it's becoming very difficult to distend the both wall of the uterus. Another common finding of the is the periosteal fibrosis. Periosteal fibrosis is the most common hysteroscopic findings in our study. Okay, that is a very common finding in the patients affected by the female genital tuberculosis can be seen up to in positive tubercular patient can be seen in 67% of cases. I will show the exactly where the periosteal fibrosis area are here. Sorry. Sorry for this. I think that yes. Hmm. Periosteal fibrosis. I come to that. I'll just show you guys the image of periosteal fibrosis because here it is not visible properly. I'll just keep it and show the next finding, and I'll come to the periosteal fibrosis. Another common finding is the polypoid endometrium. That is where the endometrium appears lighter or paler than the usual and more appreciated on the proliferative phase. This thing is a result of the chronic tubercular infection leading to the thickening of the endometrium, like you can see in this area. These are the polypoid endometrium layer. Another very rare but very characteristic finding is the snowflake appearance. You can see small whitish endometriums are seen in the atrophic cavity are situated here. This gives rise of the snowflake appearance of the endometrium. It's a very rare finding, but it can be seen in patients suffering from long duration of the female genital tuberculosis. Another common finding of the female genital tuberculosis is the patient suffering from the tubercle seen in the various organs. It can be seen in the endometrium. It can be seen on the cervical canal. One can seen in the vagina also. These are the cervical tubercle. You can see the presence of the tubercles on the cervix. Here you can see presence of the tubercle on the posterior vaginal wall. Endometrial tubercles are very characteristic of the female genital tubercles and very specific finding also. Here you can see multiple tubercles are situated in the endometrium and it giving rise to tubercular endometrium. These are the small nodules on the endometrium due to the central caseous necrosis caused by the tuberculosis. Here you can see after a course of 6 months of radiotherapy in the same patient, how the tubercles has been disappeared. These are the intrauterine adhesions of various grades can be seen in the patients with with the female genital tuberculosis. Intrauterine adhesions are the bands of fibrous tissue developed into the endometrial cavity, and it can range from this flimsy adhesion to a localized adhesion to the completely obliterating the cavity or completely obliterating the cervical canal. It can be seen around 28% of patients suffering from the diagnosed cases of female genital tuberculosis. Now coming to the laparoscopic findings, most coming. Okay, let's begin. Here you can see the laparoscopic tubercles are miliary tubercles on the various organs. Here on the fallopian tube, you are seeing at present how in the early stage tubercles are present. Here you are seeing the tubercles are present in the gut peritoneal cavity, on the ovary, and on the tubercles of the tube. So tubercles can be seen on the any areas of the abdominal cavity. Tubercles are due to the formation due to the central necrosis of the tubercle affected area by the tuberculosis. These tiny nodules may be seen on the various organ and can be seen almost 50% of the patient suffering from the female genital tuberculosis. Now I come into the next finding, that is the caseous nodules. You can see that here there's a caseous nodules can be seen on the peritoneal cavity, abdomen, and can be seen on the omentum area. Next finding is the tubes. The tubes female ends are often affected, leading to the infertility in the population. Here you can see the tubes can be affected in a various way. I will show you an image next how the tubes can be infected. Here you can see the edematous tube, and another here you can see the all the finger-like projection of the female end has been disappeared and fused to form an agglutinated female end. This kind of tube cannot capture the ovum during the time of ovulation. Thus, will lead to the infertility, and only hope for the pregnancy in these cases are the IVF. Next finding is the encysted fluid collection. Here you can see it can be found in any pelvic visceral near the pelvic visceral organ. The encysted fluid collection often it seen as a bluish discoloration. Sometimes these are the rigid late by appearance tube, which are straight in nature. Normal appearance are not present, and the block as the ismoampullariant, all of we know are the very characteristic of the female genital tuberculosis. Thickened end cornual end is also one of the common findings on laparoscopy. As you can see, the thickening of the cornual end forming a bulge like material due to the infections of the tuberculosis are very common in this cornual end. Tubal diverticula, you can see here how tubal diverticulas are formed due to the affected tubes are affected by these are the early infections of the fallopian tube. Now coming to the beaded tube appearance. Beaded tube appearance are very classical and specific findings that with small nodules or bead-like structure along the length. These are due to the salpingitis isthmic nodosa. These are abdominal adhesions are very non-specific findings but can be seen more than 90% of patients having the female genital tuberculosis. Abdominal adhesions can be of various grade from single solitary adhesions to the completely gross adhesion of the endometrium. So sometimes they form a curtain hanging appearance where the uterus are hidden, where the curtain-like momentum hanging beneath it. Okay, sometimes can we then are coming to the next findings. Sometimes there can be the interfixation of dye. Here you can see when you are in the patient with the tuberculosis, you can find the dyes are interfested due to the lymphatic area. Hydrosalpinx or pyosalpinx can be seen in the female genital tuberculosis, but they are very non-specific findings. Tubo-ovarian mass is a very common finding, can be seen around 20% to 30% of patients suffering from the tuberculosis. If it is a more, it should be always treated with the tubercular therapy. Sometimes gross chronic and female genital tuberculosis can give rise to the frozen pelvis appearance. Here you can see due to the tuberculosis, there is a formation of a frozen pelvis-like appearance. Almost all the pelvic organs have been sticking together. Now these are the various findings you can see on the fallopian tubes. It's a wide range of manifestation of the female genital tuberculosis and is the most common area affected and can give any of these findings on the laparoscopy of these patients. This I have already discussed. One of the common finding is the perihepatic adhesion or this can be seen almost around the 90% of the patients suffering from the female genital tuberculosis. It is also can be seen in the patient suffering from the PID or chlamydia infection, that is a Fitzhugh-Curtis syndrome. It is also a non-specific features. These are the very specific features, that is the miliary tubercle and the caseous nodules on the cavity can be seen on the any abdominal organ or pelvic organ, and these are the specific features of the tuberculosis. Now coming to the important part, what are these findings are summarized over here, but what is the important of these findings? I have discussed all these findings we have published a study where we have seen retrospectively around 16,000 of women had gone in our institute for diagnostic hysterolaparoscopy. We have taken the positive patients. That is only the biopsy proven positive patients were around only 309, whereas around 1084 patients had a laparoscopic and hysteroscopic features suggestive of the tuberculosis, or all this manifestation can be seen in this type of among all these women. But only 309 had positive on the endometrial biopsy or via other methods, whereas 775 patients, although having such kind of findings on the hysteroscopy or laparoscopy, they didn't show the positive on these traditional diagnostic methods. So what we did as a logistic regression analysis between the patient with who have positive histopathological finding or any other method that is proven diagnostic of the tuberculosis patient, and this woman who didn't have any traditional test positive. We have analyzed the what are the predictive powers of these findings accordingly after the comparison, and it gives us this result here. You can see only around these few findings did have a very diagnostic and highly diagnostic finding. Although this cannot be a conclusive finding because it is only a single center study. Coming to the importance of this diagnosis of female genital tuberculosis from the point of laparoscopy and hysteroscopy, I have already mentioned what are the drawbacks of these traditional methods of findings. Even though you cannot see the patients are negative, they do suffer from the infertility. So all of these investigations are most often negative in the women are infertility who are often healthy otherwise also. Moreover, one relies on this investigation. If missed, they are not going to be treated by the ARTT therapy and their fertility treatment will be delayed and their goal to conceive will also be delayed. So the diagnostic histolaboratory, what are the advantage of this? This gives us a comprehensive picture of the stage of the disease of tuberculosis and what reproductive organs are involved. If the tubes are involved grossly, there is no chance of delaying their pregnancy or delaying their treatment because the tubes are already affected. They need to go through the anti-tubercular therapy followed by IVF. Also, this gives a basis of starting the anti-tubercular therapy and also prognosticate this patient's condition. If the patient's uterus and fallopian tube are both are grossly affected, of course their fertility potential will be grossly decreased and they do have a poor prognosis. Sometimes these DHL findings will help you guys to consult the patient and counseling them what they are going through. It gives a direct impression of a treatment plan also. Before, sometimes we see due there the thin endometrium in our country, it is not growing or there is an endometrial adhesion. Before you transfer, you may need to consider such patients to a diagnostic hysterolaparoscopy, and if you find any highly diagnostic features suspicious, better to treat them with an anti-tubercular therapy before proceeding for the further transfer. Sometimes it gives us to assess the uterine cavity and tubercle in the same setting also. So it is better if you find any of these highly diagnostic finding to start directly with the anti-tubercular therapy. And if you find this any of the suspicious features, it's and along with any other history of tuberculosis like low BMI, oligomer past history of tuberculosis, or patient is suffering from long duration of fertility, it's better to start with the anti-tubercular therapy. So this was my take home a message for you guys. This study you can find in this BJOG, British Journal of Obstetrics and Gynecology. We have published from our institute, Bansal Hospital, in 2023. So thank you everyone for patience listening. And also I like to thank the Indian Fertility Society team, especially the MP chapter and my mentor, Dr. Priya Bhabil. Over to you, Dr. Ashita.
Thank you so much, Dr. Rana. This was a really insightful session. So I think we should be taking the questions now. One second. Actually, I just got log out once. I think I'm not having the previous
Okay,
question.
I can see
Yeah,
some
I can see
questions.
only one question. Yeah.
Dr. Nidhi has asked, if we do biopsy in follicular phase, there may be chance of false negative report. The honest answer will be there will be always will be a chance of having a false negative report even you do the biopsy on the proliferative follicular phase or proliferative phase also. Doing biopsy in the secondary phase doesn't give you much more advantage to diagnosis, but in most often it is a traditionally seen in that the more positive results are found in the when we do the biopsy around the 21-24 days or that's it. And culturing the menstrual blood on a day 1 and day 2 because it is easy to collect, nothing to do with any other thing. The next question was asked by the Dr. Shalini. What can be done in pale atrophic endometrium? Of course, if it is you are suspecting is this a pale atrophic endometrium, it's due to the tuberculosis. It's better to give a 6 month course of the tubercular therapy and then proceed that it with the hormonal therapy to see how it is responding or not. But often, if the basilis endometrium has been involved and destroyed, often the prognosis will be poor. Next question is another was that how to confirm the diagnosis of tubal TB. I am afraid that there is no clear-cut diagnostic method, but I have already discussed what are the critical or key findings that we can see in the patient suffering from the female genital tuberculosis, how the tubes do look on these patients, and if you see such kind of findings, you should think of it. Any more questions? Uh, okay, so another question has come pop up. Shapna has asked, a patient with a thin endometrium not responding to ATT, PRP, any other suggestion? Of course, I have already been told you the basalis layer is already been destroyed or the myometrium has been involved. Nothing much you won't be do. Even if PRP therapies aren't be working in these patients. PRP therapies are not actually useful in the patient suffering from the tuberculosis, thin endometrium due to tuberculosis. PRP doesn't respond that well.
I think there are no more questions. Okay, one more question is there by Dr. Pragya. TB culture take long time. Should we send it in all cases?
That depends on how your practice is and where you are practicing. TB culture do take a long time, as I have discussed, but culture is a traditional diagnostic methods, and if the culture comes positive, you will be definitely knowing that there's a positive case. And also, if within the 6 weeks the negative test do come, if in 6 weeks it is a nothing, then it's a negative test too. But mostly nowadays it's preferred to have a CVNet or a MTB reef assay are more useful, especially in the subgroup of subfertility patients. How to identify basal layer is involved. Two things you can do here to identify the basal. One is the transvaginal ultrasound. If viewers cannot see what you see usually the triple line in the proliferative phase after around 11 to 14 days of the estrogen course. If you cannot see the outer line of the triple line, most likely the basal layer may involve if it is a known case of the a patient has tuberculosis. And another way, if you can diagnose on the hysteroscopy directly, on the hysteroscopy, if you are seeing a pale endometrium that is with granulated appearance, it's likely the basal layer has been involved. Or sometimes, if the gross adhesion, there's a complete obliteration of the cavity, or in seen, then the most likely the basal layer of the endometrium has already been destroyed.
I think you have answered all the questions. If there will be any other question, you can post it when the recording will be out. I think we can stop the session here now. Thank you so very much, Dr. Rana. Thank you, IFS.
Yes. Thank you, everyone.
Oh, thanks.